Most people think neuropathy is a pain condition. They come in and they say, my feet burn, my legs tingle, I can't sleep at night because of the sensations. And I hear that, and I take that very seriously. But when I'm evaluating a neuropathy patient, when I'm thinking about what the real stakes are, I'm often less focused on their pain scores than I am on one question. Can they walk? Because the burning will disrupt your sleep, but a fall can end your independence. And in my clinic, I've learned that balance and gait aren't just secondary outcomes. They're often the most important ones. I had a patient, and let's call her Margaret. She came in with burning feet, tingling, the classic presentation. When I asked her what her biggest concern was, she didn't say burning. She said, I stopped going to church alone because I'm afraid I'll fall in the parking lot and nobody will be there. And that stopped me because what she was describing wasn't just a symptom. It was her life getting smaller. And that is a conversation we don't have enough in neuropathy care. Here's something that doesn't get talked about enough. Falls are one of the leading causes of injury-related deaths in adults over 65. And peripheral neuropathy is one of the most significant modifiable risk factors for falls. But the deeper impact isn't just the fall itself. It's the fear of falling. Patients start to restrict their movements. They stop walking the dog. They stop going out at night. They stop doing the things that keep them active and connected. And here's the part that makes this so difficult. That restriction makes everything worse. Less movement means less circulation to the feet. Less circulation means less nerve nutrition. And less activity means muscle deconditioning, which means even worse balance. So what starts off as just a caution becomes a pattern that accelerates decline. That's why I consider balance a primary outcome, not something just nice to have. Now, why does neuropathy affect balance so specifically? Your feet are constantly sending signals to your brain. What's the surface like? Where's my weight? Is the ground even? This is called proprioception, your position sense, and it's one of the first things that peripheral neuropathy disrupts. When those signals become degraded, the brain starts compensating. It leans more on vision, which is why patients feel worse in the dark. It recruits the inner ear. It widens the stance. But compensations have limits, and when they break down, that's when people fall. Here's a distinction I want you to hold on to. Pain improved does not equal function improved, and function can improve even when symptoms remain. I have patients who come in at a 6 out of 10 on the pain scale. 2 months in, they're only at a 5. If that's the only metric that we're tracking, that looks like minimal progress, but their balance scores have moved. Their gait has improved. Their confidence walking unassisted has changed significantly. They're moving more, and they're less afraid. Pain is a symptom. Function is the outcome. When I'm evaluating whether care is working, I want to know, can they walk through a parking lot without holding their spouse's arm? Can they navigate their house at night? Can they be at their granddaughter's graduation without fear of losing their footing? Those are the questions that matter. So what does this look like in clinic? At 360 Physical Medicine, balance and gait assessment are built into how we evaluate every neuropathy patient, not as an afterthought, as a core part of understanding where they are and what's at risk. We use standardized balance testing, static and dynamic stability, so we can track real changes across visits. We look at gait, not just whether someone is limping, but the quality and confidence of their stride. Are they shuffling, hesitating, looking down constantly? And we use functional measures, real-world proxies for independence. The reason objective testing matters is that patients often underreport limitation because they normalize it, or they don't want to seem like they're complaining. Objective measurements cuts through all of that. The numbers don't have an agenda. So I want to leave you with this. When a patient walks through my door, yes, I want to reduce the burning. Yes, I want to improve the sensations, but the real goal, is not a better number on a pain scale. The goal is that you can walk to your car alone, that you can go to church, that you can be at the moments that matter without fear being the thing that decides whether you show up or not. Neuropathy doesn't just hurt, it takes things from people. And the measure of whether care is actually working is whether we're giving those things back. That's what we're here to do. Now, before I go, has balance ever come up in a conversation with your doctor about neuropathy? Tell me in the comments, because in my experience, most patients say no, and that's exactly the problem.